Next, coming to Plummer-Vinson syndrome or Patterson-Brown-Kelly syndrome. It is due to the atrophy of muscles of the alimentary tract. The characteristic features are SAD, KIG, SAD, KIG, S for stomatitis, A for eclohydria, D for dysphagia, K for koilonychia, I for iron deficiency anemia, and D for glossitis. Diagnosis is done by barium swallow. On doing barium swallow, there is wet in the post-cricoid region. It is due to subepithelial fibrosis. And the 10% cases develop post-cricoid carcinoma. And this disease predisposes to carcinoma of esophagus, carcinoma of buccal mucosa, pharynx, and stomach. Treatment: correct anemia along with deficiencies of B12 and B6 and dilation of the webbed area with esophageal boogies. Next, coming to motility disorders. Motility disorders are classified into two types, hyper and hypo. Hypermotility disorders are cricopharyngeal spasm, diffuse esophageal spasm, and nutcracker esophagus. In case of cricopharyngeal spasm, there is failure of the upper esophageal sphincter to relax. There is incoordination between the relaxation of the upper esophageal sphincter and the contractions of the pharynx. Diffuse esophageal spasm. Here there are non-peristaltic or uncoordinated contractions. Peristalsis is alternate contractions and relaxations to propel the bolus. Here there are non-peristaltic contractions. In nutcracker, there are peristaltic or coordinated but strong contractions in the body of the esophagus. Clinical features are dysphagia, odynophagia, substernal pain. On doing barium swallow, there are segmented esophageal spasms which look like rosary bead or corkscrew type appearance. Treatment by lower esophagus dilation. Coming to hypomotility disorders, cardiac achalasia and gastroesophageal reflex disease. In cardiac achalasia, lower esophageal sphincter relaxation is absent, whereas in GERD, the function of the lower esophageal sphincter is decreased. Peristalsis in the body of the esophagus is absent, and there is high pressure in the lower esophageal sphincter. Clinical features: dysphagia first to liquids and then to solids. It is reversed to the malignancy and strictures, and there is regurgitation of the swallowed food, and it is more during the night. Diagnosis by barium swallow. There is dilated esophagus at the body and the narrowed lower end. It gives rat tail lower end and bird beak appearance. Coming to manometric. There is low pressure in the body of the esophagus and high pressure at lower esophageal sphincter. Endoscopy is done to exclude benign strictures and the development of cancer, which is a complication of this disorder. Treatment: modified Heller's operation. It is a myotomy of the lower esophageal. It is the myotomy of the lower esophagus. If surgery is contraindicated, forceful pneumatic dilation is done. Coming to GERD. The causes are pregnancy, hiatus hernia, scleroderma, drugs. Drugs that relax the smooth muscle like anticholinergics, beta-adrenergics, calcium channel blockers. Clinical features: regurgitation, substernal pain, and heartburn. Treatment: elevation of head of the bed at night and avoiding food 3 hours before sleep. Avoid antacids, smoking, alcohol, caffeine, chocolates, mints, and drugs like H2 receptor antagonists. And surgeries: Nissen's fundoplication. Complications include laryngeal, lung complications, esophageal complications, ear complications. Laryngeal complications are like cancer, laryngitis, ulcers, and lung asthma, bronchiectasis, aspiration pneumonia, esophagus, esophagitis, Barrett's esophagus, benign esophageal stricture. Coming to ear, it may be otitis media. Schatzki's ring. It's also called lower esophageal ring. It occurs at the junction of the squamous and the columnar epithelium at the lower end. Junction of the squamous and columnar epithelium at the lower end. Clinical features are intermittent dysphagia and its treatment is by esophageal dilation. Thank you.